Hello, everybody. Welcome to Ardexia Insights. I'm Dr. Aditi Joshi, and this is where we cut through the hype to explore healthcare innovation that actually works. Each episode, I talk with leaders and practitioners navigating digital transformation, telemedicine, AI, RPM, and system change, sharing real stories from the trenches and practical strategies for creating healthcare change people can trust. So let's dive in. I am very happy today to speak to my old friend, Dr. Matt Sakamoto. We go way back. Matt is an intersection of clinical care, technology, and health system scale. He's a primary care physician in San Francisco and a virtualist who deeply understands the daily reality of digital care delivery. Crucially, he is fellowship trained in clinical informatics at UCSF, focusing on virtual care efficiency tools for the EHR. In his role as a regional CMIO and clinician advisor to many early stage health tech companies, and is passionate about exploring and implementing effective evidence based AI into clinical workflows. Welcome, Matt. So nice to see you.
Thanks. Always fun to chat.
So let's start out. We're going to go obviously virtualist, obviously virtual care, as I'd like to start out. So you're a virtualist and your workflow is 100% digital these days, right? And you're also a CMIO focused on EHR tools. I was thinking back to the paper we wrote about digital empathy in chat and AI, which, honestly, we wrote it well before this year of AI just bursting through all the news. So tell us, what is the single biggest disconnect you see between how a physician uses the AHR telehealth system, which is often designed for billing, and the patient's expectation of a warm, human digital experience?
No, great question. I think a lot of the things that we've been seeing, and this even came, even before the AI thing, is like we're trying to recreate brick and mortar workflows that are slow in a digital world, be it just through video visits or through other workflows. The nice thing about making a lot of things digital, be it messaging with patients or connection or even messaging within the care team, kind of the background care coordination, is that we can start to digitize those and actually not make it like we're shuffling paper around from one place to another. So I think that's been the biggest unlock, is thinking about like, how could we do this better, not how do we recreate an old fax-based workflow.
Right. It's like recreating the waiting room. It's like, why did we do that? Why did we do that? I know we have to put people somewhere where they wait, but maybe there's a better thing. So I want to go back to this because I think when people think of digital empathy, traditionally it was always about the video visits. But now that we're moving into all this asynchronous communication, we have AI tools, chatbots, etc., that we use in written patient messaging. How do you actually increase that empathy, not make it more robotic, taking a step further than what we even wrote about?
Yeah. I think a lot of it, the key to empathy is trust. And that's the biggest thing. So it's kind of one, making sure trust and just clarity of communication. I think those are the two biggest things. So just one, making sure that the patient felt heard. And it's a lot of it, to be honest, it's a lot of the things that we do verbally, just now doing it in written format. So like kind of either the teach back or the read back, saying just to clarify, I want to make sure that I heard you, or I read this correctly. Is this, your plan going forward? Did you understand the plan that we had for you going forward? So it is one of those, just like, did you hear me? Yes, we heard you. Okay, we also heard you. So it's that clarity and connection, I think, that drives a lot of it, more so than what specific word to use or things like that.
Yeah, I love that. We talk about trust because this is exactly it, right? You talk about trust. And so um, I was thinking about trust as a metric a lot when I was talking to Ardexia because we talk about patient trust, but clinicians and physicians are losing trust in the system, which ends up being I mean, there's a lot of reasons for it, right? But this is also why there is a barrier in using digital tools. And so how do we actually make it easier for them? And so this is a great way to talk about how do you think about the EHR workflow and how do we think about how it should succeed, right? So you're a primary care physician, you're an informaticist. And so how have you seen the most successful example of a tool, an AI tool, maybe, but any tool that's been implemented in the EHR that actually genuinely reduce the cognitive load of a virtual visit or a primary care physician's visit?
Yeah, I mean, I think the other big buzzword that we've been seeing is the AI scribes. I think so much of documentation burden was trying to capture things, both either for billing, but also just for like details in clinical care. And it has been personally really freeing to be able to actually just like look the patient in the eye and be able to just talk with them and not worry about having to capture all the details, and trusting that that's getting captured in the background. and then kind of looking across our organization, that's been so yeah, AI scribes or ambient documentation has been the one technology I've seen that I did not have to like force people to try to do. Even telehealth. I feel like people kind of hopped in half-heartedly, and it was really just the pandemic that pushed a lot of people to it. But this is the first time I've had to create wait lists for technology versus before it's like, oh, please just try it, please just pilot it. And I think the unlock for that is it just fits into the workflow. Doctors talk with patients, clinicians talk with patients, and this just happens in the background. Every other technology that we put in, be it electronic health records, even telehealth, was you as a clinician have to change the way that you approach the visit. Versus this one is like, let's just take a step back and kind of automatically in the background do a lot of things there. And I think that's been one of the reasons for really impressive uptake. And like I said, I think just quality of life. At worst, it's been neutral. And then, like I said, large majorities have said that it's made a significant impact on just work-life balance.
Yeah, that's a great way to put it. It doesn't actually change the workflow, it just sits there. I can use it in telemedicine. I was telling somebody else today that, you know, in a telemedicine visit, I don't actually need to tell the patient that I'm doing it because they can't see me. They don't see it turned on. I do, of course, but they don't know that the difference is happening, right? They don't see the difference happening the way they do in an in-person visit where, you've probably heard this too. And a lot of my colleagues have said, I don't have to turn away from them if they're listening. I don't actually even have to do any of that because I can trust it. So it has made a real difference in the way that they feel that they're even interacting with their patients, which is really cool as well.
I'll reflect on that real quickly too, because I think I agree. Like when I'm doing I kind of call it the duck swimming underwater thing. Like when I'm talking with a patient, my fingers are often like at the keyboard typing and doing those things, and they just can't really see that. But I've realized even cognitively now, when I'm able to incorporate ambient documentation, there's just that level of focus that I'm able to have. And from a cognitive burden standpoint as well, that's made a significant difference.
Yeah, absolutely. So, yeah. And I think that we're seeing a lot of that. I have heard, and this is an easily surmountable problem, is that some specialties are saying, it doesn't work exactly the way that it's structured in the note. But again, now that it's scaling and people are using it, this is a good problem to have, but they just have to make it much more relevant to each specialty, right? But it works really well for primary care, works well in emergency department, works well for telemedicine, certainly. So, one thing that you're really, you both speak up a lot about is how do you do evidence-based work? Both of us agree on this has to be part of how you present it to health systems, physicians, et cetera. How do you think about that when you talk about AI, which tends to be very early on, and some of it isn't really used for clinical decision making? Do you see that it's required, or do you think that there is a different way to think about evidence-based when we talk about like ambient scribes, for example?
I mean, there's how we generate evidence, I think needs to change. And I think that's the difference now. Because before, we would put out a medicine or a medication and we check to see how that worked on patients. With AI, it's a little bit of a shifting sands where by design, it's kind of learning, changing, and adapting. I think generally in a good way, right? It'll personalize to a particular situation or a patient population. So I think we have to really switch from having this like ironclad RCT, randomized clinical trial approach that takes 10 years to gather data and publish on, and really having kind of more of this monitoring and reacting and kind of in real time, how do you do these experiments safely in terms of deploying new technology, but also really monitoring it, checking for bias, making sure that you're not having unintended consequences or downstream consequences. Because if the doctor can do things faster, but it's like loading up the staff on a lot more paperwork than they're fast, or hopefully not more paperwork, but like a lot more tasks downstream that the staff is not ready to handle, then that's like also something that you need to look for. So I think really bringing implementation science concepts into this realm and like really again tracking real-time data is going to be the new way of looking at this again, rather than longer RCTs that are going out.
Yeah, that would be great too. Because I mean, startups and companies who are building those, they don't have that kind of time. So there has to be some way to figure out how to do both. Do both and to still make it safe. But I have a question for you because, okay, Stanford, and you can go, he sent out, there's a new no harm study that recently was in preprint, and they were talking and looked at a number of large language models, and they found that they could produce harmful medical advice at non-trivial rates. It was about like 22%. through errors of omission, meaning they missed a critical test or they missed a critical step. So how do you, okay, so you're thinking as a CMIO now, as your role as CMIO, and you're thinking through these LLMs and AI tools from the clinical decision-making support angle, not the operations administrative. How do you think through studies like that, and how do you actually, again, build the evidence for those type of tools to use it in the future, or do you think we're not there?
I think, and again, it's a different way of evaluating it because humans are also fallible, right? Like I'm thinking of the times that they would drop 100 pages of nursing notes and other things for a hospital transfer and trying to sort through that. So I guess what is the standard? I think that we're going off of. I think going for perfect is too difficult because one, it's never going to be perfect, and again, that's also a shifting sands kind of thing. I think this is actually one where, yeah, again, doing kind of those head-to-head things and saying, is it at least probably non-inferiority is what we should go for rather than perfection. And like, what are the different ways of looking at it, right? Is this something that you should actually have the clinician self-review, search the electronic health record as a first pass, and then tack on oh, hey, here's the summary. Again, I don't know what the exact workflow or sequence of these things are, but looking at it that way rather than saying like, okay, this missed X amount of things in a vacuum because I guarantee that I also miss some percentage of things also as a human looking at the chart. So it's almost like having think I guess more of the AI as the intern, trust but verify sort of thing, and maybe go back and check, at least in these early stages.
I agree. It's like the assist, right? Because you still need someone to overlook it. You still take a look at it. And I think then it's okay, right? Even if they omit it, the goal is, use primary care me as emergency medicine. I'll say, okay, well, yes, I would also add this, and I'm going to still do this test because I want to, and my experience says it. But I mean, what I'm worried about is that for people who are newer to medicine and they're in their training, how do you get to that point if these tools are available? And I don't know. I know you probably don't have an answer, but these are things that keep me up at night as we think about what's going to happen in medicine in like 30, 40 years.
Yeah, that's been super interesting. And again, it's actually all of the different AI tools, the open evidence for looking back at the literature, AI Scribes for, one, it takes on the documentation piece, but also it starts to suggest diagnoses, right? So again, as a trainee and as a learner, where does that process of differential diagnosis come in if you already have something kind of anchoring you really, right, on certain things? So that's, been a discussion I've also had with colleagues at different institutions saying, what does this look like at the medical school level, resident level, and even new attending level, I think. So short answers, I think we're not sure. There's definitely going to be a lot of interesting stuff coming out over the next months to years.
Within primary care, like how do people feel about the accountability, right? Where do they want to see the accountability? Let's say that something does go wrong, right? We talk about the black box a lot. We don't know what's in there. We cannot understand it. And it's not our job. Like, I don't think most physicians want to learn and go back to school for one more thing, right? So like, how do we get through it so that what would make us feel safer so that clinicians want to use AI tools for clinical decision support as opposed to the operations and admin?
Yeah. I think it always still goes to that trust but verify piece, right? Like we have pop-up alerts that show drug interactions and things like that. And also kind of learning to be like, okay, I did go to med school and have used these things. Yes, this is an alert, but I feel comfortable overriding this because X, Y, or Z. This patient is a special case. I think it just, AI assisted clinical decision support just kind of takes that to the next level. So I think a lot of it is just kind of continuing with that level of continuing medical education and learning. A recommendation from AI is almost like any test result that you have. It still requires some level of interpretation, and I guess that also gives me pause because it's also a good thing. I think I'll have my job for a while because there is human in the loop and there is some critical thinking and evaluation that I think still goes into it.
Yeah, absolutely. Speaking of which, being a virtualist, it's relatively new. Not for you and me, maybe, but it's relatively new in the world. But the primary focus is digital care. So how do you see AI informatics transform that role?
I think one piece, it's funny, I was just talking about this with a group of colleagues. The idea of virtualist, people think of telehealth as video visits only, right? I think now, especially as you and I wrote about too, a lot of virtual care is this asynchronous messaging. And that's where large language models and AI can really thrive because you can start to, again, for the things that are clinically appropriate, start to maybe even auto answer or start to collect additional information automatically that the human in the loop doesn't have to think about first. I still think, final arbiter is the clinician that puts in orders and puts in the diagnoses, but there are if a patient says I have a cough, there are always going to be like the same 5 to 8 questions I will ask as a follow up. So if something can automatically do that and then send it over to me, that's a huge one, faster for the patient, and then two, a huge cognitive burden off of me. So that's where I see kind of AI being this kind of next layer of communication with the patient. I think never fully on autopilot just yet. But like, again, there's a lot of things I tend to automatically ask anyway, and I can see that portion be automated.
Yeah, absolutely. I can understand that too, because part of it we want to make it a little bit more efficient without necessarily taking on a larger patient population burden, right? That's
Yeah.
especially primary care. You guys have a lot to do already. Okay, so Jesse, a lot of what we're trying to do is improve how clinicians adopt these tools so they don't feel nearly as afraid of it or just to feel like it doesn't work for them. There's a lot of reasons why that happens. And so, you think through like trust, just not getting the right information, right? We can self-report what we think is wrong. We can even be followed and see what's wrong, but that isn't always what people are solving for. So how do you see with AI and in virtual care that you're working on, how do you actually convince someone going in the future who wants to do what you're doing that, this is going to be that they should try adopting it?
Yeah. I think a lot of it just is being curious, right? There's people that want to, there are different folks that will want to just go in, do a job, go home. And I think there's sort of another way of like, okay, how do we do this better for the patient, for us, for the care team? So I think that's, I guess, to my detriment oftentimes. And this is a theme from medical school residency up through now, is I've always asked, how could we do this better? And again, but I think it takes that curiosity, and probably the other reason why I do a lot of consulting with other companies is it's really really fun to see how people think outside of the box to solve different problems. So I think, and that for me, living in that intersection of seeing patients, doing patient care, understanding kind of the needs of the larger health system, and with a startup being like, okay, these are actually different tools that are approaching a problem differently. Again, not just digitizing a brick and mortar workflow.
I ask this question to almost everybody because a lot of people do advise startups as physicians. What do you tell them for this particular problem?
Is ask. I mean, for me, it's like let's not do a square peg round hole kind of thing. It's like ask people, not just the questions, but the whole care team. Like, what are the problems that you're trying to solve? Start with the problem, and I think that's the people skip that step. So it's like defining the problem is 90% of.
Yes, I mean I agree with you. You got to figure out the right problem. So one of the things that we had to figure out and do is figure out how do you get the right problem. And right now it is manual and it is difficult because sometimes even us, I can think that the problem is one thing. Like for example, in the beginning of when we were doing Jefferson's telemedicine, we were like, oh, parents are having a hard time figuring out that they have to set up a different chart for their child as opposed to calling in under their name. And so we thought that maybe it was an issue with the website or where it was listed. And that actually wasn't it. It was actually with the actual registration, right? But we didn't know that until we went in there. And when the patient would ask us, it was one thing. But if we actually went in and tried to do it as a patient, then we found the real problem. So there's all these little things that happen all the time. So for my last question, I just want to ask you for the advice since you do a lot of teaching and training, and so advice for the next generation, for a young physician who wants to do what you're doing, whether it's virtualist, informatics, AI within all these spaces. What is like one piece of advice that you wish you had known and where they should focus their energy for success in their career?
I love that. I think I didn't realize big how big like the community of kind of like physician entrepreneurs and physician innovators are. So like seek that out. And if it's not at your institution, there's like in between social media and other things, podcasts, seek those out because I think like that serves as a good role model for me. And I come into this community, got to meet great people like yourself. And I think like that's something that I wish I had found a little earlier.
Yeah, I love that too. Same. How else would we have met? We didn't meet in person for years. We knew each other online
Years.
for a long time. Well, thank you, Matt, for being here. And thank you, everyone, for listening to our Ardexia Insights. This conversation sparked ideas about your own healthcare innovation challenges, especially with clinicians. Visit us at ardexia.io to explore how we can work together from strategy sessions to long-term consulting partnerships or simply a strategy session. Because people everywhere, especially clinicians and patients, deserve a kind of innovative healthcare that stabilizes societies. Until next time, let's keep creating healthcare change people can trust. Thank you, Matt, for being here with us.
Always a great time.